Hello everyone, my name is Felipe, I'm from Brazil. I'm going to talk about neurocisticercose, about the manifest of this emerging parasitic infection. This presentation aims to demonstrate the imaging findings of this disease and its most common complications. Neurocisticercose is the larval phase of Taenia solium, the human central nervous system. According to the location of the parasite, it can be divided into parenchymal and extraparenchymal forms, which present with different clinical and imaging findings. Parenchymal form has four well-defined anatomopathological stages, which have a good correlation to imaging findings. Extraparenchymal neurocisticercose includes interventricular and subarachnoid forms. In the ventricular stage, a cyst can be characterized next to the gray-white junction with a thin margin with a little or no contrast enhancement. A scolex can be seen within the cyst, and this pathognomonic of neurocisticercose. Heavily T2 weighted sequences are very useful to depict the scolex, and there is no inflammatory reaction in the surrounding brain parenchyma. Here we see a 30-year-old man with headaches. There is a cystic lesion with a scolex inside without perilesional edema. Scolex usually shows a high signal on the double eye, as we see on the yellow arrow. In the colloidal stage, the larvae begin to degenerate, determining edema surrounding the lesion and enhancement of the capsule. In the granular nodular stage, the lesion retracts and forms a nodule that shows ring or solid enhancement with or without discrete surrounding edema. Here we see the MRI of a 35-year-old man with seizures, demonstrating a retracted lesion in the granular nodular stage with mild ring enhancement or post-contrast T1 sequence, mild perilesional edema on flare, and intralesional calcification in situ star. The calcified stage demonstrates only small areas of hypointensity on MRI, especially on SWI, as we see in this asymptomatic 40-year-old man, and is considered a residual finding. However, the onset of contrast enhancement and perilesional edema are consistent with reactivation, as we see in the 62-year-old woman with a history of neurocisticercose treated 7 years ago with seizures since then. The patient presented a recent onset of dyslalia, drowsiness, tremors, and bilateral upper limb paresis. The report of the last MRI scan performed at another hospital 1 year earlier described multiple gross cortical subcortical calcifications without perilesional edema or post-contrast enhancement, and the images were not available. Current MRI shows calcified lesions, but now with peripheral contrast enhancement and perilesional edema on flare, consistent with reactivation of the inflammatory process. The intraventricular form most commonly affects the fourth ventricle, followed by the third ventricle, the lateral ventricles, and the sylvius aqueduct. It's potentially lethal due to the risk of acute obstructive hydrocephalus. Here we see a case complicated by obstruction in a 49-year-old man with frequent headaches and hand tremors. Sagittal fiesta shows a cystic lesion between the fourth ventricle and the lower parts of the sylvius aqueduct with a scolex on the red arrow, which is also seen on the double eye. On axial flare, we see signs of hypertensive hydrocephalus. Here there is another similar case of the intraventricular neurocisticercose complicated by obstruction. Here there is another similar case, but now we can see a thin ependymal line in contrast enhancement on the yellow arrows consistent with ventriculitis. The subarachnoid neurocisticercose frequently infiltrates the basal cistern and sylvian fissure, sometimes with scolex, as we see in this 50-year-old woman with headaches, or sometimes multiloculated cyst without scolex called racemose form, as in this 42-year-old man with headaches and dizziness. Here we see another case of racemose form, but now complicated by vasculitis, demonstrated by arterial wall enhancement in the right M1 segment of the middle cerebral artery. Here we see the racemose neurocisticercose in the craniocervical junction, complicated by hydrocephalus. This is an MRI of a 52-year-old man after catheter placement due to entrapment of the fourth ventricle. Cysticerci are seen in the craniocervical junction and in the cisterna magna. In conclusion, familiarity with imaging findings in neurocisticercose may help in early diagnosis, appropriate treatment decisions, and follow-up of patients. Thank you for your attention.